Hello, everyone. This is Dr. Kamal again. This is the third part and the last part of the acid-base disorders, and we'll talk about the high anion gap metabolic acidosis. In the first part, we talked about the different respiratory issues between respiratory acidosis, respiratory alkalosis, how to find the different etiologies and how to treat it. The second part of the acid-base disorder series, we talked about normal anion gap metabolic acidosis and how to differentiate between the different factors or etiologies between renal loss and GI loss, and how to differentiate between them to be able to treat them and correct the acidosis. Um, in this last part of the acid-base disorders, we'll talk about metabolic acidosis, but the elevated anion gap or the high anion gap. So again, we looked at the VBG or the ABG. We found the pH less than 7.35. So we know it's acidosis. Then we looked at the bicarb and we found the bicarb is less than 20, so we know it's metabolic acidosis. Then we looked at the anion gap, which is the sodium minus the chloride and the bicarb, and we found it more than 12, so we call it elevated anion gap metabolic acidosis, right? If it was 8 to 12, we call it normal anion gap metabolic acidosis, which we talked about. So again, if you remember, if you see any metabolic acidosis, there are three questions. First one, anion gap, you need to calculate, and you need also this anion gap to correct it for the albumin. And we learned how to correct the anion gap for the albumin, which is 4 minus 4 is the normal albumin level minus whatever albumin level of the patient. Let's say it's 3 or 2, and you multiply 2.5 and add it to the actual anion gap that you already calculated here. So let's say the albumin in the patient's serum is like 3. So you add 2.5 to the anion gap. So if it was 11, so you add 11 to 12.5. So that's uh, 13.5. If the albumin is 1, then you add 3 to 0.5. So 7.5 to the 11, which will be 18.5, right? So this is how you correct the anion gap for the albumin. So first thing, we calculated the anion gap to know if it's normal anion gap or elevated, because obviously the etiologies are different. And if it's elevated anion gap, we calculate what we call the delta ratio. And the delta ratio is an equation to answer one question: if there is concurrent metabolic disorder with the high anion gap metabolic acidosis or not, which we will learn about in a little bit. The number three, it's the Winter's formula, which to calculate the compensated or the expected compensation of the PCO2. So Winter's formula, calculate the expected PaCO2. So it's 1.5 multiply HCO3 plus 8, and you give it a range plus or minus 2. If it's within the expected, if you do a VPG and the PaCO2 is within the range, then you have compensated metabolic acidosis. If it's higher, then you have respiratory acidosis with the metabolic acidosis. If the PCO2 is lower than the expected PCO2, then you have metabolic respiratory alkalosis with the metabolic acidosis, right? And as we learned earlier here, about major difference between normal anion gap and high anion gap. In the normal anion gap, you have bicarb loss, but in the high anion gap, you have actual acid that's added to the bloodstream that's increasing the unmeasured anions, but also increasing the anion gap. And this acid can be intrinsic or extrinsic. And the different acids, there's different mnemonics you can pick, and all these mnemonics is just um, abbreviation or indication of one thing, it's increased in direct acid in the blood, whether again intrinsic or extrinsic. So there is different mnemonics for that. I'm sure everyone is aware of this, whether the mud piles or the updated one, which is more comprehensive, which is the gold mark. So let's go through this mnemonic, whether the mud piles or the gold mark. So number one, M stands for methanol, which forms formic acid. Again, we added acid. Uremia, which is, you know, can increase the sulfate, phosphate, organics, different acids. It can be D, diabetic ketoacidosis. And again, here you are adding acid. P, which stands for propylene glycol or paraldehyde, or the isoniazid iron, sometimes in bone metabolic errors that can increase different acids. L stands for lactic acidosis, and we'll learn about the different types of lactic acidosis, whether it's type A or type B. E in the mud pile stands for ethylene glycol, which get um, sorry, which gets switched to glycolic or oxalic acid, and again the salicylate, which is an acid salicylic acid, which comes from aspirin overdose. So this is the mud piles. On the other side, the gold mark G stands for glycols like ethylene glycol, propylene glycol. O stands for oxoproline, and oxoproline, you get that accumulated in chronic paracetamol use. L stands for L-lactate, which is the type of lactate that you find in actual sepsis or shock or ischemia or just hypoperfusion states. D stands for D-lactate, which you find in GI issues like short bowel syndrome or malabsorption. M stands for methanol. A stands for aspirin or salicylic acid. R stands for renal failure or uremia. K stands for ketones, and you can find ketones in three different pathologies, whether it's DKA or starvation ketoacidosis or alcoholic ketoacidosis. And we talked here about lactic acid, and lactic acid, probably one of the most common causes of high anion gap metabolic acidosis. So let's just talk briefly about lactic acid. Lactic acid, it can be two types, type A and type B. And the main difference, type A, it's an indication of tissue hypoperfusion or hypoxia. Why? Because we know that in the Krebs cycle and the glucose metabolism, we have mainly aerobic metabolism. If you're having good oxygen, but if you are having low perfusion, that decrease the oxygen supply to the tissue, so the tissue switch from aerobic to anaerobic if you have hypoperfusion. And if you are using the anaerobic pathway, you are producing a lot of lactic acid. Which type of lactic acid? It's called type A. While on the other side, type B, it's not necessarily tissue perfusion, it can be other causes other than tissue hypoperfusion. Like what? So here, type A, again, remember it's hypoperfusion, so you can see it in different types of shock, any kind of shock. Septic shock, distributive, cardiogenic, cardiac arrest, hypovolemic, severe anemia, sometimes in carbon monoxide poisoning because it causes mitochondrial dysfunction and also cause desaturation of the oxygen on the hemoglobin, sometimes if there's mesenteric or limb ischemia. On the other side, type B lactic acid, it's usually um, can be different deficiencies or medications. So it can be because of metformin toxicity. So we know metformin, one of the side effects of metformin cause lactic acidosis. So lactic acidosis here doesn't it's usually type B, so it's not hypoperfusion, but you can see the lactic acid really high in those patients. Sometimes in hepatic failure because impaired lactate clearance, sometimes between like B1 deficiency, mitochondrial toxicity, seizures, exercise, propofol infusion syndrome, poor bowel, all these different etiologies, which is definitely way less common than type A. So that's the lactic acidosis, right? Then here we'll talk about the delta ratio. The delta ratio, again, for any metabolic acidosis, number one, we calculate the anion gap to differentiate if it's normal anion gap metabolic acidosis or high anion gap metabolic acidosis. And if it's high anion gap metabolic acidosis, we calculate delta ratio. And delta ratio here, it's mainly to detect mixed metabolic disorder. So it can be either high anion gap metabolic acidosis plus normal anion gap metabolic acidosis or plus metabolic alkalosis, which we'll learn about in a little bit. So what's the delta ratio? Again, I want to remind you that delta ratio we only use in high anion gap metabolic acidosis. And the way it works, it has numerator and denominator. So how to calculate it? It's the anion gap that you calculated, which is high anion gap. So it has to be more than 12. So it's 13 and above. So it can be 14, 15, etc. So this number will be always more than 12, right? Then over 24 minus the bicarb. The bicarb, we know we have metabolic acidosis, so the bicarb here will be always less than 24. And this number will be higher if the bicarb is lower. For example, let's say the bicarb is, let's say 18. So 24 minus 18 will be 6, right? Let's say the bicarb is less than 18, it's 12. So it will be 24 minus 12, which will be 12. So the lower the bicarb number, the higher the denominator. And this actually represents the bicarb deficit. So you are basically calculating on the higher number, the excess anion gap, which is the anion gap minus 12, over the bicarb deficit, which is saying how much bicarb fell below the normal, which is the 24, and how much anion gap rose above the normal, which is 12. I hope this makes sense because the interpretation, I think it's a little bit challenging to understand it, but it's not that complicated. Let's say you do the delta ratio and you find it, so the range, between zero point 0.4 to 2. So it's below zero point 0.4, that means the bicarb dropped far more than the anion gap rose. That means you have too much drop in the bicarb. That's not explained by the high anion gap. That means you are losing a lot of bicarb. That means you probably have normal anion gap metabolic acidosis or hyperchloremic metabolic acidosis, and this is not true higher anion gap. So if the delta ratio is below zero point 0.4, that means it's normal anion gap. So it's normal anion gap metabolic acidosis, but mistaken for high anion gap. Okay. And this is usually a pure normal anion gap process like bicarb loss, whether diarrhea or RTA. Okay, that makes sense now. The second scenario, you have the delta ratio between zero point 0.4 to zero point 0.8. And this interpretation, usually it's high anion gap plus normal anion gap. Because here again, because it's less than 1, so you still have more bicarb loss more than the anion gap increased. So again, the bicarb fall more than the expected elevation in the anion gap. So you probably have two metabolic acidosis here. High anion gap metabolic acidosis causing the high anion gap, and also you are having bicarb loss that's causing, the normal anion gap. I hope this makes sense. And this is actually, it's not uncommon. We see it in different scenarios like DKA and diarrhea. So the DKA will increase the ketones, causing high anion gap. The DKA increase the ketones, causing high anion gap metabolic acidosis, but also you can have diarrhea with it, and in the diarrhea, you are losing bicarb, so you are causing normal anion gap metabolic acidosis, right? Another scenario, you are having lactic acidosis plus RTA. Lactic acidosis that gonna cause high anion gap metabolic acidosis, and RTA, you're losing the bicarb in the kidney, causing normal anion gap metabolic acidosis. Or uremia plus saline. Uremia will cause what? High anion gap. And the saline, again, we talked about it. The saline you are giving, let's say nasal saline, you are giving NaCl, so you are increasing the chloride. In response to the chloride, you don't want the anions to go more than the cations. So what you do, you try to decrease the bicarb to compensate for the increase in the chloride. So that will be a case that you can see this mixed pattern, right? So those are the cases that you can see normal metabolic acidosis that can be interpreted by the delta ratio, whether just normal anion gap only if the delta ratio below zero point 0.4, or if it's zero point 0.4 to zero point 0.8 that mix between high anion gap 2 and normal anion gap. If it's 1 to 2, that's ideal. That means, yeah, you're having pure high anion gap metabolic acidosis. So you have here bicarb fall, which is the lower number, and proportionally, you're having a anion gap increase. So you have decrease in the bicarb that's almost equal to increase in the anion gap or matches the anion gap. In those two cases, you're having the drop in the bicarb more than the increase in the anion gap. So here again, the anion gap rise appropriately or proportionally matched by the bicarb fold. So here, no hidden second process. And this is expected in the pure high anion gap metabolic acidosis. And that can be any cause of high anion gap metabolic acidosis, like uncomplicated DKA, lactic acidosis, methanol, ethylene glycol poisoning, all that in isolation without, RTA or saline or diarrhea or any second etiology that can be causing this scenario, right? The third or the fourth interpretation for the delta ratio, you have delta ratio more than 4. Sorry, the delta ratio more than 2. And in this case, you have high anion gap acidosis, but also you have metabolic alkalosis. And what does this mean? This means that the HCO3 is higher than the expected range for the anion gap. That means usually the HCO3 is higher than expected, and that's usually means there's concurrent alkalotic process here that's increasing the bicarb. It's the same if we remember the compensation, and when we were calculating, the respiratory compensation with Winter's formula, for example, and we find the PaCO2 is low or high more than the expected compensation, we call it concurrent respiratory acidosis or respiratory alkalosis in addition to the metabolic acidosis. So here is the same concept, right? And when can you see this? Actually, this is common as well because sometimes DKA and vomiting, they match together. So the DKA will increase the ketone, will cause high anion gap metabolic acidosis, and the vomiting, you will lose the chloride. So decrease the chloride will increase the bicarb, as we'll talk about. So this is a common cause of metabolic alkalosis. Or another scenario would be lactic acidosis and diuretics. We know lactic acidosis will cause hyaline gap metabolic acidosis, but diuretics cause metabolic alkalosis, or sometimes salicylate and volume contraction alkalosis. The volume contraction alkalosis, you have high in the bicarb, and then the salicylate that cause, salicylic acid, which is part of the mud piles or gold mark, which cause high anion gap metabolic acidosis, right? So here again, just to summarize this, delta ratio is only for high anion gap metabolic acidosis, and it compares how much bicarb you lost below the 24, which is the normal range, compared to how much anion gap increased more than the normal. And by matching both together or comparing both together, you can know if there's different metabolic disorder that's concurrent. So again, if it's less than zero point 0.4, that means you have hyperchloremic normal anion gap, and this is not high anion gap. If it's between zero point 0.4 to zero point 0.8, that means it's mixed, which is high anion gap acidosis, metabolic acidosis, and normal anion gap metabolic acidosis. If it's 1 to 2, that's usually just pure high anion gap metabolic acidosis, and if it's more than 2, that means it's high anion gap acidosis plus metabolic alkalosis, right? So let's find this example together, talk about this example together. I think just a small practice so we can understand better. I'm not sure if those numbers are very clear, but here the pH is 7.28, the PaCO2 is 28, the bicarb is 13, sodium is 140, chloride is 100, albumin is 4, which is normal, right? So step number one, we look at the pH. So the pH here is 7.28, right? So that means it's acidemia. Okay. We want to know what is the primary metabolic disorder. So we look at the bicarb. The bicarb is 13, so it's below 20, so it's low. So if it's 13, that means it's metabolic acidosis. Acidosis because the pH is low, metabolic because the bicarb is low. And as we said, in any metabolic acidosis, we need three things. One, anion gap, right, to differentiate the etiology. But also, if you have high anion gap, you need to calculate the delta to find if there is another metabolic disorder. Number three is the compensation through Winter's formula. So Winter's formula here is to calculate the expected CO2 to see if there is respiratory compensation or not. So it's 1.5 multiply the bicarb. The bicarb here is 13 plus 8. So this is around 27.5. And you give it a range. So it's 27.5 plus or minus 2. Okay, what is the measured CO2 here? It's 28, right? We got this by the VBG. So the VBG shows the CO2 is 28. So 28 actually it's within the range. That means it's appropriate compensation. But theoretically, let's say if the CO2 instead of 28, it's let's say 21 or 35. 21, that means it's less than what's expected. So that means there's concurrent respiratory alkalosis. If it's 35, that's higher than the expected CO2, which is in this range, that means there is respiratory acidosis. And here will be mixed disorder between respiratory alkalosis and metabolic acidosis, or respiratory acidosis with metabolic acidosis. But this is not the case here because again, the CO2 is 28, which is within the range. So this means you have appropriate compensation without any respiratory disorder. Okay, so we calculated the nine gap. Sorry, we calculated the compensation. Now it's time to calculate the nine gap. The nine gap equals sodium minus bicarb and chloride combined, so 140 minus 113, that's 27. So 27, the normal range is 8 to 12. So you have 27, that's elevated high anion gap metabolic acidosis. So we calculated the anion gap, we find it elevated. Second step, we said any elevated high anion gap metabolic acidosis, we calculate the delta ratio. So let's calculate the delta ratio. And the delta ratio is the anion gap that we just calculated minus the normal, which is 12, right? So this says how much anion gap increases more than the normal. Then on the other side, we do 24 minus the bicarb, which we want to know how much the bicarb dropped lower than the normal, because the normal bicarb is 24, here it's 13, right? So 27 minus 12 is 15, 24 minus 13 is 11. So it's 15 over 11, which is around 1.36. And here we said if it's 1 to 2, that means if it's between 1 to 2 range, that means it's pure high anion gap metabolic acidosis without any hidden disorder. So what the diagnosis here? The diagnosis here, it's pure high anion gap metabolic acidosis. Why it's pure? Because the delta is 1 to 2. Why high anion? Because the anion gap is 27. Why metabolic? Because the bicarb is lower than 20. Why it's acidosis? Because the pH is lower than 7.35. Then we need to comment if there is a respiratory compensation, yes or no. And if there is no respiratory compensation, that means it's either respiratory acidosis or respiratory alkalosis. And the whole thing of this whole sentence is to find the etiology. So the workup here will be to work up for DKA, to look for lactic acid if they are infected, if they are bleeding, if they're having ischemia, to look for toxins, alcohol, all that, and look for kidney function. This is just a summary about specific treatment for each cause that can cause high anion gap metabolic acidosis. I will not go through the details of it, but let's just go through it very fast. DKA, you have diabetic ketoacidosis. So diabetic, the glucose will be high, the glucose will be above 250. Ketosis, then you have ketone bodies that you can test for in the blood or the urine. That's this ketone bodies cause the acidosis, so DKA. So it's, glucose high, ketones high, there's acidosis, and usually the potassium can be high initially. And the treatment for that, it's IV insulin fusion. It's usually zero point 0.1 unit per kilogram per hour. Before the insulin, you need to check the potassium. So you don't start the insulin unless the potassium above 3.5. If it's the potassium below 3.5, you need to replace the potassium before giving insulin. But number one that you should do in the DKA, it's aggressive IV fluid. And the fluid that we usually use is the normal saline, but just be cautious again because normal saline can cause increase in the chloride and that drops the bicarb and that can cause normal and gap metabolic acidosis. And those are cautions, watch for the edema, hypoglycemia, hypokalemia, and don't stop the insulin until anion gap normalized. Then The lactic acidosis, if the lactic acid more than 2, sometimes it can be type A or type B. Type A, hypoperfusion. Type B, you need to get drug history. And here you're trying to treat the cause. Usually, if it's type A, that means hypoperfusion that you can see in septic shock. So you need to give IV fluid, you need to give IV fluid, you need to give antibiotics, and sometimes even vasopressors. If there's hypoxia, you need to correct it. If it's type B and is caused by metformin or another drug, then you stop the offending drug. And usually we don't give bicarb unless the pH is severely low, usually below 7.1, because 7.1, that severe acidosis can cause tissue hypoxia, can cause even cardiac arrest. After that, uremia. Remember when we talked about the RTA? So remember RTA cause normal anion gap metabolic acidosis, but uremia cause high anion gap metabolic acidosis, and that's easy to diagnose. You'll see the BioN high, the creatinine is high. You will find some electrolyte imbalances. Sometimes they need dialysis. And sometimes you can give bicarb as a bridge to dialysis if it's severe acidosis, but here the dialysis will be the definitive treatment. Sometimes it's salicylate toxicity. So salicylate is salicylic acid. So it causes high anion gap metabolic acidosis, but sometimes it causes concurrent respiratory alkalosis as well. How does this? It's by increasing respiratory rate and CNS stimulation. So it causes respiratory alkalosis and usually can cause also tinnitus. We talked about the hyperventilation by the CNS stimulation. And what you do here is usually urine alkalization. And sometimes those patients can need hemodialysis if the level is severe or is causing altered mental status or severe renal failure. Um, the After that, some alcohol like methanol or ethylene glycol, and here you will find the osmolar gap is elevated and there's high anion gap acidosis as well. There's sometimes visual changes if it's methanol. Sometimes if it's ethylene glycol, you can find oxalate crystals in the urine. And the treatment for that usually fomepizole. Fomepizole, it's usually a loading dose of 15 milligram per kilogram, and you give it IV. And sometimes this is an indication for hemodialysis, that hemodialysis, which we'll talk about in another video. This is an indication for hemodialysis. And here's time very critical. You need to start dialysis as soon as you suspect this. Um, and sometimes, again, it can be alcoholic ketoacidosis. And in that case, you need to give IV dextrose like glucose, and you need to give thiamine before the glucose. Remember Wernicke-Korsakoff syndrome. Again, when it comes to the routine bicarb, we don't have a really good data about routine sodium bicarb in high anion gap metabolic acidosis. So usually it's not recommended unless you have severe pH or severe acidosis that's below 7.1. Sometimes you do it if you have severe salicylate toxicity, TCS toxicity, or uremia, just as a bridge to dialysis, because dialysis will be the definitive treatment here. Um, Again, sodium bicarb is just a bridge here. It's not treatment. It's nothing. It just buys you time till you either find the etiology and treat it, whether DKA or uremia or whatever, or sometimes this patient need dialysis just for the acidosis. Okay. Um, the last part we'll talk about will be metabolic alkalosis. We just talked about the metabolic acidosis. So we'll talk about the alkalosis. So metabolic means increase in the bicarb. And we'll talk separately about the different etiologies of increase the bicarb, but just this is a summary or mind map about different causes of increase the bicarb. Usually when I remember metabolic alkalosis, I remember the CHEM7 um, or BMP lab. So we have on the BMP sodium, potassium, we have chloride, we have bicarb, we have BUN, we have creatinine and glucose. So three things in this diagram can cause increase in the bicarb. First, it's the potassium. So if you have hypokalemia, that can cause increase in the bicarb. How? So you have here hypokalemia, you have low potassium in the bloodstream. So what will happen? The potassium mainly intracellular, so the potassium will go from intracellular to extracellular to compensate or try to normalize this hypokalemia. In exchange with the potassium that's coming out, you'll get some hydrogen inside, and this will cause metabolic alkalosis. Another thing, which can be the bicarb. The bicarb, usually, if you are given antacid, some antacids they have bicarb in it, and the other thing is volume depletion. So here you have concentrated bicarb because of volume depletion. And the most important cause of the metabolic alkalosis would be chloride issue. Remember that we have to keep the anions stable or the same number. So if you have decrease in the chloride, you'll have increase in the bicarb to try to keep the anions normal or equivalent to the cations. So if you have any pathology that decrease the chloride, that means the bicarb will increase to compensate. And you can have chloride loss whether in the kidney or whether in the GI. GI, like vomiting or someone having tube feeding and you're doing suctioning because the stomach acid, it has HCl, so you're losing acid and you're losing chloride as well. Or sometimes it's kidney loss, like diuretic, for example, loop diuretic. You lose sodium, you lose potassium, and you lose chloride. And remember, in the metabolic acidosis, normal anion gap, we're checking the urine anion gap, but here we are checking the urine chloride because we can differentiate the metabolic alkalosis between chloride responsive and not chloride responsive. And what does this mean? Which means you are looking in the urine and you're looking for the chloride in the urine, and you find the chloride in the urine low. Oh, that's weird. Why? Because normally, if you have metabolic alkalosis, you have high HCO3. So, what's the response to high HCO3? You will try to decrease the chloride, right? How you will decrease the chloride? You excrete it. So, if you look in the urine, you'll see a lot of urine chloride, right? Why? You're trying to lose it to compensate for the high HCO3. But actually, this is not the case here. You're checking the urine and you find the chloride is low, which is weird, which means the problem is not in the HCO3 to start with. No, it's a chloride issue to start with. So if the chloride is low, that means the HCO3 just increased to respond to the chloride. So if the urine chloride is low, that means you have chloride loss. And that means you're either losing the chloride in GI or kidney, and that's what we call chloride responsive. That means the pathology is not in the bicarb itself, the pathology in the chloride, and the increase in the bicarb is just a response to the decrease in the chloride. The other scenario, you check the urine chloride and you find it elevated, and if it's elevated, we call it not chloride problem, not chloride responsive. Because again, this is mainly will be bicarb problem. So if you have increased the bicarb, the body will try to decrease the chloride to keep the anion level the same. How you'll keep the chloride level down, you excrete it, so you'll find the urine chloride high. So this is just a brief um, summary about metabolic alkalosis, but let's just go through it very fast. Metabolic alkalosis, that means the pH is more than 7.45. Metabolic, that means the bicarb is high, so it's at least above 26. What's the compensation? If it's metabolic, will be respiratory. If it's alkalosis, will be acidosis, right? How do you do respiratory acidosis? You increase the CO2 by hypoventilation, so you decrease the respiratory rate, so you decrease the clearance of the CO2 to cause respiratory acidosis to compensate for the metabolic alkalosis. And remember, the respiratory compensation is fast, so there is no acute and chronic compensation. But the opposite, when we were talking about the renal compensation to the respiratory problems, we're talking acute and chronic because the renal compensation is slow. So here's respiratory compensation, so it's faster. So you can either use this equation to calculate the expected PCO2 for the compensation, or you can just use this. I think it's simpler, which says you have a metabolic alkalosis, so you have increase in the bicarb. So for each increase in one in the bicarb, the PaCO2 should rise zero point 0.5 to zero point 0.7. And again, so you have increased the HCO3, so what you'll do, you increase the CO2. So if the normal level of CO2, let's say 40, you can go up to 44, 45, etc. But usually you stop at the 55 because at 55, that means um, you're having very low respiratory rate, and this can cause hypoxia. So the hypoxia here usually prevents the severe hypoventilation, and that's usually how it works. And again, if it's the PaCO2 is more than the expected, that means you have concurrent respiratory acidosis. If the PCO2 is less than expected, that means you have concurrent respiratory alkalosis. And again, respiratory metabolic alkalosis, it's all about increasing the HCO3. There's usually two concepts here, generation versus maintenance. Generation means what is the initial event that raises the HCO3 or caused the hydrogen loss. And this is must be identified and treated. Maintenance, the which means what is the reason the kidney fails to excrete the HCO3? Because in metabolic alkalosis, for whatever reason, generated that disorder, you have HCO3. So if you have healthy kidney, the healthy kidney should kick this HCO3 out and correct it. So usually, if you get metabolic acidosis and you have healthy kidney, the kidney usually excrete the HCO3. So if you're having maintained metabolic alkalosis, that sometimes can mean you have kidney problem, and this can be usually between volume depletion if you're having like pre-renal AKI, or you're having hypokalemia or hyperaldosteronism. And again, the urine chloride is very important to differentiate if it's chloride responsive or not chloride responsive. So if the urine chloride is low, that means it's chloride problem. That means it's chloride responsive. That means you need to give NaCl, you need to give them chloride. That means they are losing the chloride, whether in the kidney or the GI. If the urine chloride is above 40, that means the chloride is not the problem to start with. So that's chloride resistant, which means even if you give NaCl, it will not respond to saline. And here you need to treat the underlying cause. Again, different causes of metabolic alkalosis. First, GI loss of hydrogen and chloride, and this is usually chloride responsive because you are losing chloride, and this you can see in different scenarios. Vomiting is the most common, nasogastric suction, bulimia, pyloric stenosis, and all that. And here you have direct loss of hydrogen that cause acidosis, and the chloride, decreasing the chloride will increase the bicarb as a compensation. What the kidney will do, the kidney will try to retain and not lose the chloride. So if you check the urine chloride, you will find it low. So if it's low urine chloride, that means it's chloride responsive, and the treatment will be chloride or nasal or normal saline. Another scenario, which is the diuretic. The diuretic, you are losing the chloride in the kidney, for example, loop or thiazide or post-diuretic state, you're losing a lot of chloride. And if you're losing a lot of chloride, then the kidney will try to retain chloride. So the urine chloride will be less than 25. And again, here you can give some chloride, but also usually it's diuretic or medication induced. So you need to stop whatever offending agent. On the other side, the um, chloride resistant. Chloride resistant, usually the urine chloride will be high. That means you are losing chloride because it's a compensation um, of the increase in the HCO3. And this can be sometimes mineralocorticoid excess, like primary hyperaldo, or ACTH is high, or Cushing syndrome, or renal arterial stenosis that can cause secondary hyperaldo or sometimes kidney problems. So the aldosterone here will cause hydrogen ion loss and also potassium secretion. So the response will be bicarb retention, so you'll increase the bicarb, causing the alkalosis. Another example would be alkali administration. Sometimes if you are giving a lot of bicarb or milk alkali syndrome, it has some bicarb in it, or sometimes massive blood transfusion because we put citrate to prevent the blood to clot, but citrate later can convert to bicarb. And again, here it's not chloride problem, so it's chloride resistant. So there is no um, importance or need to give chloride. Again, post hypercapnia, which we talked about. So if you have respiratory acidosis, that's chronic, like COPD. So you have increased CO2 chronically. With the compensation to that, you increase the bicarb. Then they come to the hospital, and they already, you know, compensated, but they have COPD, so you start them on whether intubation or BiPAP. So what you do here with the BiPAP or the intubation, you decrease the CO2. So you correct the acidosis, but you keep the bicarb elevated, what we call post-hypercapnic metabolic alkalosis. And again, as we discussed, sometimes it's hypokalemia. Anything that can cause hypokalemia will cause metabolic alkalosis. Again, if you have here low potassium, the potassium will shift from the cell to outside and then respond, or in exchange, the hydrogen ion will go to the cell to compensate for that. So it's usually potassium shift out of the cell to correct the hypokalemia, and exchange the hydrogen will shift intracellular, causing intracellular acidosis and extracellular alkalosis. And here the treatment, of course, is to correct the potassium mainly, or any other electrolyte imbalances. Sometimes it's magnesium problem. So if you have hypomagnesemia, you will have hypokalemia as well. So sometimes the reason for the hypokalemia could be low magnesium, and you need to correct that. Again, the symptoms and signs, those are the symptoms and signs of the alkalosis. Again, the alkalosis can cause decrease in the calcium, can cause hypokalemia, can cause hypomagnesemia. And the main treatment, you want to know if it's chloride responsive, which means the main pathology is in the chloride loss. And the urine chloride here is low. And the way you correct it, you give um, sodium chloride or normal saline, and you try to correct the cause. If it's chloride resistant, that means the urine chloride will be more than 40, and you try in here to look for different etiologies to correct them. Okay. Um, I'll try to summarize very briefly. I know this was very comprehensive. Thank you for watching the whole video. Again, just a brief summary. We look at the pH, the normal between 7.35 to 7.45. If it's below 7.35, that's acidosis. If it's acidosis and high PaCO2, that means it's respiratory acidosis. And that's mainly because of hypoventilation, decreasing the respiratory rate. And we need to figure out whether the hypoventilation is because of central etiology or peripheral etiology. And we talked about it. If the acidosis accompanied with low bicarb, that means it's metabolic acidosis. And the metabolic acidosis, we need to know the compensation. If there is respiratory compensation, we look for Winter's formula, but also we look for the anion gap to differentiate, is it normal anion gap or high anion gap? If it's normal anion gap, usually it's bicarb loss, and we do the urine anion gap and the urine anion gap to differentiate if this bicarb loss, GI or renal. Then also from the anion gap, if we see it's high anion gap, we look for the etiology, but also we calculate the delta ratio to see if there's any other concurrent metabolic disorder. And we talked what it means if the delta below zero point 0.4 or between zero point 0.4 to zero point 0.8 or between 1 to 2 or above 2. So this is the acidosis in summary. If the pH above 7.45, that's alkalosis. If the PCO2 is low, that means it's respiratory alkalosis. That means you are breathing very fast, whether CNS etiology or systemic disease. If the alkalosis is accompanied with high bicarb, that means it's metabolic alkalosis, and that means it can be chloride responsive or unresponsive. We calculate the urine chloride. If the urine chloride is low, that means it's chloride responsive. We give them chloride or normal saline. If the urine chloride is high, that means they are not chloride responsive. That means look for other etiologies. We talked about how hypokalemia can cause it. We talked about the bicarb, whether you are given sodium bicarb or the volume depletion or sometimes antacids. And we talked about the chloride loss, how can it cause increase in the bicarb and the chloride loss, whether it's GI, most commonly in vomiting, or kidney, most commonly in diuretics. Thank you for watching that.